also important to know some of the key metrics by which hospitals are evaluated in terms of their utilization or their use. One of the key measures for hospitalizations are discharges, which is an indicator of how many people are accessing and receiving care at the hospital. So this is the number of patients discharged from the hospital per 1,000 residents, for example. So the national average of discharges per 1,000 is 114.4 discharges. Women have more discharges than men, which means they utilize inpatient healthcare services more than men, even when adjusted for childbearing age. This is true. The western part of the United States has the fewest discharges. The Northeast has the highest. So as somebody who is looking to have a career in a hospital, the Northeast is one of the best places in terms of the amount of access and the amount of utilization that patients have in terms of hospital care. Inpatient days, that's a night spent in the hospital by a patient, counted every 24-hour period, so that's counted as an inpatient day. We also have days of care, so in cumulative number of days in the hospital spent over a certain period. So this might be 533.9 days of care per 1,000 people per year. So if we know that the national average is 114 discharges, you have 114 per 1,000 people, you know that they are on average among those 114 people spending 553 days per care. What that averages out to is an average length of stay, total days of care divided by number of discharges, of approximately 4.8 per 1,000 of the population. So on average, statistically speaking, the number of days that if you go into the hospital and are admitted as an inpatient, the average is 4.8 days. Of course, we know from statistics that averages are skewed by the outliers, right? So most people going into the hospital, of course, don't spend almost 5 days in the hospital. There are many people that have much, much longer lengths of stay. One of the key indicators of quality and one of the ways in which hospitals are trying to improve their performance is actually to reduce the length of stay in hospitals in the United States, which will, of course, reduce their amount of revenue, but will likely result in less expensive care because the most expensive place you can receive care is in the hospital. One interesting thing to note about average length of stay, federal hospitals have the longest length of stay, the VA, for example, and for-profit has the shortest. Now, you can attribute that to a lot of things, but one of the things most people attribute it to is that for-profit hospitals have a much larger profit incentive, and so they've put in place systems and practices that have allowed for patients to be able to stay inpatient as short as possible, maximizing their likelihood of effective reimbursement. What we also see is that there are other factors that need to be analyzed in terms of understanding a hospital's performance in its operations. One measure we use is the average daily census. We've already talked about this in another course, the number of inpatients receiving care daily. We also have capacity, the average number of beds that are available, and then the occupancy rate, which is the average daily census divided by capacity. Now, usual occupancy rate for most hospitals is between 75 and 65% for most of the 20th century. As many of patient beds became less and less occupied in the latter part of the 20th century, this is when we saw that period of mergers and consolidation where many inpatient beds were being removed and replaced with ambulatory care and other kinds of services in many community hospitals. Most community hospitals have less than 300 beds. What we see is that, in fact, there's a very, very small proportion that have more than 500. Some of the largest hospitals in the country are in places like Florida, New York City, Chicago, but that, in fact, the vast majority are smaller than 300 beds, and about an even proportion between about 100 to 25 beds and between 100 and 300 beds. Here's what we know about hospital costs. In 2010, the average cost per stay was $9,700. Now, you think about an average stay being 4.8 days, and you do the math, it costs about $2,000 a day to be in the hospital on average. The costs incurred for those is primarily incurred by those ages 45 to 84. The costs are averaged over ages 85 and higher. Of course, Medicare accounts for the highest amount of inpatient hospital spending. And of course, the main drivers of hospital costs are the intensity of the services, the level of specialty, the invasiveness of the procedures, and all of those things, as well as growth of the population, more people being counted as discharges. What we see from nonprofit hospitals is, in particular, these hospitals. These are your nonprofit, primarily community hospitals, are expected to perform a certain amount of public good or community service in order to receive their tax-exempt status. What their tax-exempt status gives them is that they're not being taxed on their property and they're not being taxed on their revenues. So what we see here is, of course, no profits from the hospital are distributed to any individual. These profits are then reinvested back into the hospital and into the community. Also, there are limits on what hospital executives can be paid. They cannot be paid exorbitantly high salaries because it is deemed that those monies could be better spent on community benefit or public goods, or even charity care. And so there's sort of a cap that the IRS puts on executive pay as a proportion of the overall revenue of nonprofit hospitals. Now, some of you may be wondering, well, what really is the distinction between a profit or nonprofit hospital? Both hospitals have to make a profit. They have to have a margin or a certain amount of revenue that they generate above their expenses in order to stay in business. The only difference between nonprofit and for-profit hospitals is what they do with that margin. What do they do with that difference? A for-profit hospital takes that margin and they return it back to their investors or their shareholders. That's what they're required by law to do. Nonprofit hospitals are required by law to make that investment back into the community, whether it's charity care, whether it's community projects, whether it is investing in the hospital itself. So they're not allowed to distribute that to anybody else. That's the main difference between nonprofit and for-profit hospitals. One of the big challenges for nonprofit hospitals today is that they often compete head-on in the same market with for-profit hospitals, which means that nonprofit hospitals are driven to act like and behave like more like for-profit hospitals than their nonprofit hospital peers. And this is a theory known as institutional theory, which says that the most competitive institutions will drive those others either out of the market or to behave more like them in the market. And so what we see is, now this is not an issue in Connecticut because there are no for-profit hospitals in Connecticut. But if we were in New York or if we were in New Jersey or Massachusetts, what we would see is that for-profit hospitals drive what the nonprofit hospitals are going to do. We also see that nonprofit hospitals regularly come under fire for not providing enough charity care. And so now the IRS requires a high level of documentation on what kinds of community benefit and what expenses are associated with that community benefit for nonprofit hospitals. Their tax exemption for nonprofit hospitals has been very controversial. Numerous times it has been proposed at the federal level that nonprofit hospitals, because they function more or less the same as for-profit hospitals, for-profit hospital chains have lobbied and said that this tax exemption is an unfair advantage for nonprofit hospitals. And so this has been a debate that has happened over and over and over again. And there's a lot of debate about what constitutes a community benefit. Is reinvestment in your institution a community benefit? Should those funds be spent explicitly on community programs, on public health, on improving safe housing? How diffuse do we define what benefits the community? And so there's been a lot of debate over that definition given by the IRS, and there's been lots of debates among hospital administrators about what counts as community benefit. What we also see is that the Affordable Care Act has put new pressures on nonprofit institutions. They now require nonprofit hospitals to do a community health needs assessment. We've talked about this a little bit already in class. And then to implement their community benefit strategies based on the needs, based on what is identified from the community health needs assessment. So it's a much more direct level of accountability. You do a research plan, you do an environmental scan, you find out what the needs of the community are, and then you are required by the Affordable Care Act, if you want to keep your tax exempt status, to show how you are addressing those specific needs. It's very important that institutions now have written policies on charity care, financial assistance, and access to emergency care. They also limit what can be charged according to a financial assistance policy. So it's no longer okay if someone doesn't have insurance to be able to charge an unlimited amount for those procedures. So there has to be a clearly written financial assistance policy. There is only so far now that hospitals can go in terms of charging and collection activities, which is another consumer protection put in by the ACA. And we also see that in addition to the reporting on community health needs, that they have to provide audited financial statements to the IRS or face an excise tax. So we see many, many more community protections and individual protections put in place related to community hospitals. Now, here's where the management part comes in. There are a number of different pieces of hospitals that, of course, require a strong support from a governance structure, and you're going to learn much more about hospital governance in management of healthcare organizations. But just to understand very quickly, there's sort of a three-pronged approach to hospital governance in hospitals in the United States. There is a board of trustees. It is the governing body. It's often sometimes called the board of directors, and they oversee the strategic direction and the hiring and firing of the CEO. The CEO is the chief administrator and often is also the president of the hospital. They oversee all aspects of the operation of that hospital. And then there is the medical staff. And the medical staff is headed up by the chief of staff or the chief medical officer, who oversees all of the providers in the hospital. This has been a shift of power that really has happened, moving power away from the trustees and the board of governors, then to physicians, and then to senior managers. So it used to be that the trustees, the benefactors who provided all of the funding to run these public and charity hospitals in the late 1800s and 1900s, that was where all the power lies. And what the trustees wanted was what happened in the hospital. Then the physicians came to have much, much more power over what happened, and the chief medical officer was usually the most powerful person in the hospital as physicians really began to take over and run most U.S. medical centers. Now what we see is that senior managers, the C-suite, the CEOs, the COO, the CIO, and high-level clinical managers now really drive the operations of the hospital, not the physicians who are now mainly just employees of the hospital like everybody else, and not even so much the board of trustees who do play a governance function but at a much, much higher level. The real locus of power in terms of operations in most U.S. hospitals are senior managers, which is what all of you want to become someday. We also see that a lot of hospitals and organizations have parallel operational structures. They have a clinical or medical structure that is administrative leading up to the chief of staff. And then we also have a separate administrative track, which often creates opportunities for conflicts because what's happening on the clinical side may not be entirely clear to the administrative staff, and what the administrative world is doing and the pressures that they're getting on reimbursement and regulatory issues often aren't clearly understood by clinicians. And so what we see is that there are often opportunities for conflict when the organizational structure doesn't merge or closely align those two aspects of the hospital. What we also see is that hospitals require a significant amount of certification, accreditation, and licensure. A hospital must be licensed to operate in every state. Every state sets its own standards. In the state of Connecticut, that's governed by the Department of Health. They emphasize all kinds of safety rules and regulations, including things like climate control, building codes, etc. What we also see is that hospitals usually want to be certified. They want to be certified by the American Hospital Association and or the Joint Commission. They need to do this if they're going to participate in Medicare and Medicaid. They have to qualify and comply with certain conditions for participation and meeting federal standards for health, safety, and quality. Hospitals then often want to pursue, in addition, accreditation by the Joint Commission, or if they're an osteopathic hospital, the American Osteopathic Association. Accreditation is this is a non-governmental, the Joint Commission is a non-governmental organization. This accreditation is voluntary, but it does convey a certain status or level of achievement on hospitals. This is not conferred on things like nursing homes and others where they just have to be certified and then licensed by the state. We also have other kinds of programs that really show above and beyond even Joint Commission accreditation, a really high level of quality and operational management on the part of hospitals. And so one of these is the Magnet Recognition Program. And so this is a designation conferred by the American Nursing Credentialing Center, which really recognizes excellence in nursing care and real professionalism in the nursing practice. The organizational environment that the Magnet designation requires and the way the organization has to be structured and therefore how it functions really helps to attract and attain well-qualified nurses. However, getting this Magnet recognition status is very difficult. It's a really high level of operational quality that you have to achieve. It really requires there to be very strong leadership and to promote a healthy work environment, and really is focused on quality care and improving quality care and continuous quality improvement as well. So this is something you'll often see hospitals touting, that they have Magnet designation. Of course, in the hospital, when people are caring for patients, ethical issues are likely to arise. This is also known as what we call clinical ethics. Many different kinds of ethical issues can arise in the hospital, and hospitals have to have the policies and procedures in place to deal with those issues. Usually these issues have to do with conflicts between patients and providers, in terms of sometimes when there's a lack of agreement between patients and providers, between patients and family members about the treatment plan. Oftentimes there are issues of lack of fairness or justice that happen in the hospital, and there's a wide range of issues that relate to this. So ensuring that there is informed consent for medical procedures, ensuring that patients get a copy of the patient bill of rights, making sure that patients understand about living wills and advance directives, that they have a durable power of attorney for healthcare decision making. All of these issues are typically handled either by the Organizational Ethics Committee of the hospital or the Hospital Ethics Committee. And you'll learn much more about that in the healthcare ethics class. There also are important legal issues and legal rights for hospital patients that you need to be aware of. Usually these court cases have arisen when there has been an incompetent or comatose patient where there was a question about continuing or discontinuing care. As a result of a number of these landmark cases in the late 20th century, we have something called the Patient Self-Determination Act. Patients have to be informed about their rights and receive a copy of the patient's bill of rights upon admission. And those main rights include things like a right to confidentiality, a right to give consent to medical care before it is delivered, except in case of emergency. Information, they have to be provided with adequate information on the range of treatments available for their particular diagnosis. They also have to understand that they have a right to refuse treatment if they don't want to receive it. And they also receive information about advance directives or the documents that are used for people to indicate what their wishes are should they become incapacitated to make those decisions for themselves. Informed consent for medical treatment is a really important idea in healthcare, particularly in the United States. Our understanding in healthcare is that patients have the right to choose whether or not they will receive certain kinds of treatment, and that they have the right to full and complete information about their diagnosis and treatment. And there's been a long history in medicine where people, and particularly physicians and other providers, did not provide complete information about the diagnosis and treatment and the prognosis to patients. They often thought they were sort of benevolently lying to them by not telling the patient that they had cancer because they thought it would be too distressing. And so now there's a much better understanding that patients have a right to know about their health condition and to make the decisions with a fully informed set of information at their disposal. There also has been a move toward patient-centered care, which really is an organizational commitment to involve the patient in their preferences, to provide culturally sensitive care, and to really educate patients so that they can make the best decisions about their health possible. We've also already mentioned advanced directives. These are documents that are generated that allow patients who don't have capacity at the time that they're receiving care, or particularly at the end of life, for healthcare providers and family members to know that what their wishes were. And so there are many different types of these kinds of advanced directives. One of the most common ones that comes up in inpatient setting is, of course, the do not resuscitate order, which basically requires that people, if someone goes into cardiac arrest or they stop breathing, to not perform cardiopulmonary resuscitation on them and to let them pass. There are many other much more detailed documents, such as a living will, which indicates the scope of treatments you would like to receive, or durable powers of attorney, which authorizes someone else to make decisions for you. There are lots of different ways to facilitate ethical decision-making in the hospital. Hospital ethics committees are one, but also there are lots of other people who need to get involved, including healthcare managers, who have a role to think through some of these ethical issues that occur in clinical settings and to put the needs of patients above those sometimes of the organization, and to think about ethical compliance and compliance with the law, and what to do is sometimes when those ethical ideas conflict with what maybe the law requires. And so this is one of the challenges for healthcare managers that you're going to learn a lot more about in healthcare ethics, that oftentimes healthcare managers get squeezed in the middle between what the organization needs on the one hand and what the patient or what the family needs on the other, and they have to navigate that really tricky water between fulfilling the needs of both of those parties. And you're going to learn much more about that in another class. So to conclude, U.S. hospitals have obviously significantly evolved since the 19th century. They provide the bulk of the care and are the bulk of the costs that we spend in the U.S. healthcare system. They are where the bulk of the jobs are in the U.S. healthcare system. They are still growing in many parts of the country, but we also are seeing significant consolidations and mergers, and the changing of what the role of hospital care is in the United States. We know that there are many different kinds of hospitals, and many of these structures and many of these functions, of course, are not mutually exclusive. You could be a private, community, nonprofit hospital in an urban area. So really understanding what kind of hospital, various kinds of hospitals are important to understanding how they function and the role that they serve. The Affordable Care Act has put tremendous strain on particularly nonprofit hospitals, but all hospitals, in terms of reimbursement and proving community benefit. And so this is one of the challenges that the inpatient care industry is likely to face for decades to come.